Any last minute questions? Here we go. Closing the floor in 30 seconds. 20 seconds? 10 seconds? You're out of luck. Now all I got to do is do my great Karnak invitation. The answer is, now for the question. Let's see. Dr. Vienna, why are bone nets an exclusion for multivisceral organ transplant?
At this point, yes.
Why?
Why? Because I think what happens is that I think the approach for multivisceral transplant, you have to see it in a different way. It's an attempt not to do palliative care, but actually to cure the disease. So with the immunosuppression that we give later, you have to try to make sure there's no disease left. Now in the future, with all these exciting treatments, maybe you can do a multivisceral transplant and use all these good drugs to keep the tumors from coming back and not to treat them. But right now, if we want this to succeed, if we start pushing and doing people with a lot of disease, then we're not going to prove anything.
Simple answer, trying to make it curative. Bone nets you can't cure, you can't transplant all your bones.
And furthermore, in the face of immunosuppression, those bone nets which may have been smoldering along are going to grow like you poured gasoline on a fire.
Good. You're answering the right question. The next question is, what's on the horizon for bone nets, Larry? Hey, I couldn't help it. God sent me that question. Or whoever you are.
Well, for pancreatic neuroendocrine tumors, the 70% response rate with capecitabine and temozolomide included patients who have not only liver and lymph node, but also bone mets. So the therapy is given orally, it's absorbed well and taken out throughout the entire circulation by the bloodstream. So in pancreatic neuroendocrine tumors, we have capecitabine and Xeloda. Some of these other targeted agents like Afinitor and sunitinib can also arrest the growth of bone lesions. For painful bony metastases, palliative radiation therapy can be outstanding, and then peptide receptor radiotherapy with Lutathera has activity against not only liver, lung, but also bony metastases.
Okay, another Larry one. Well, let's do another Rodrigo. Do you hook up the nerves in an organ transplant, and does it make a difference?
No, we do not hook up the nerves. The bowel has its own plexus, like nerve plexus, so we don't see a lot of difference. We just have to do a few modifications so the stomach empties a little faster. But we actually don't hook up the nerves, so you cannot have pain in the organs.
Oh, Larry, is there anybody who's developed an orally effective octreotide or somatostatin analog?
People are still working on that. People have developed octreotide analogs that are administered by nasal inhalation, and that was not very effective and very irritating locally. The problem with oral octreotide is that it's a peptide that has 8 amino acids in it, and these are the building blocks of protein. And they're very sensitive to the acidic environment of the stomach, so when you try to give an oral octreotide or oral somatostatin analog, it's broken down in the stomach and you don't get therapeutic levels. But people are still working on it.
Okay. Oh, by the way, Mia and the ISI people said there's some extra books. Make sure if you want to take one to your doc, pick up an extra copy. Thanks for reminding me, Frank. Nib and Nab, who the hell comes up with these stupid names for drugs?
Not me.
Dr. Rivera, how small a biopsy, or how small a tumor can you biopsy in the pancreas?
You can identify tumors as small as 1 to 2 millimeters. Certainly,
Can you biopsy?
you can biopsy. The yield, there's a lot of endosonographic sort of operator dependent on the yield of the biopsies, but certainly a tumor that you can see, you can biopsy. You have to have a good pathologist because the amount of cells that you're going to recover are going to be small, but you certainly can biopsy if you can see.
Remember my quote, the accuracy is proportional to the amount of meat on glass. The bigger the biopsy, the higher the accuracy. Rodrigo, any age limit on transplants?
Well, probably 100, but no. We look at the patient itself. Sometimes you would see the oldest patient.
So you transplant a 90-year-old if they were running marathons?
Yeah, we look at the patient itself. The
You
oldest we've
wouldn't
done.
necessarily exclude them just because they were old.
I don't. The oldest we've done is a 69-year-old.
I mean, look at Dr. Wallen. I mean, he's doing triathlon kind of
Right.
stuff.
It depends.
And I mean, just because you're over 65 or 70 doesn't mean that you're not just a superb athlete and in great physical shape.
Correct. So
I mean, I'm a disaster and I'm only 65.
No, we don't have any.
All right, Dr. Cole, how long should you stay on Sandostatin? Do you ever take somebody off, or you just keep adding? In other words, let's leave it there.
All right. I just wanted to interject one other comment about the previous question to Dr. Vienna. I suspect that the upper limit of age is going to move further and further as he gets older and older.
Maybe I'm 63 looking really young.
When he's 88, he'll think, what the hell? Going back to the question, Sandostatin is one of those rare drugs in the field of oncology where you continue it even if the tumor is progressing because it's often still controlling the symptomatology. Basically, about the only time we discontinue it is if the patient is completely refractory to the control of their flushing and diarrhea, and we can put them on an alternative investigational drug. But virtually all of the trials that I talked about, and that will be available on clinicaltrials.gov for carcinoid or pancreatic neuroendocrine tumors, allow continuation of the Sandostatin, even in the face of disease progression as you go on the new drug, because early on when we were doing the first phase 2 trial, where we had evaluated drugs like actinomycin or Cytoxan or you name it, if the patient was on it, progressed, we stopped it. But if they were on octreotide, even if the tumor was progressing, and that's why we were trying something new, when we stopped the octreotide, they became miserable. So we spoke to the people at Sandoz and got permission to continue the drug even in the face of disease progression. And that's true with most of the protocols to date.
You agree with that, Odo?
I sure do, and you have to recall it's the look-alike of what nature made, namely somatostatin. So it's a very powerful form of what we already have, and I think the only caveat I would say is the level, and Gene's done quite a bit of work on establishing, when too much might not be good for you. But I agree with Larry completely.
Good, but moving right along. The next question we need right into that. I mean, it's a question for you. When do you, Larry, Tom, me, when do you measure octreotide levels? And if somebody has an octreotide level of 800 micrograms per mil and has symptoms, does that indicate you should increase the dose? Or do you just do that empirically and you don't bother to measure it? And is there, in your opinion, an optimal level? Why have we kept going up? I mean, we started out 10, 20, 30. Now the national average is 40, and all the new protocols are 60. We keep moving up on the drug. I've been preaching this since Noah built the ark. But how do you use blood levels in your practice or not?
I do use blood levels, especially when we are up around 40 milligrams every 21 days. I'll get a nadir.
That's
level.
60 a month, by the way.
60 a month. But I'll do a blood level at the nadir of the next shot just to see, because I think there is a range where saturation, and I think the number between 5,000 and 10,000 pikes is a good number for therapeutic. I think if you're above 12 or 13,000, like you get with the sub-Q pump, I think you're starting to go over the top, and you may get this phenomenon of desensitization. where things get worse and not better. But I do think there's a therapeutic range.
Larry, what about you?
I do not routinely measure levels of octreotide in my clinical practice. I treat to maximum therapeutic benefit.
So you're treating symptoms only?
I'm treating symptoms only, but I have a low threshold if there is disease progression while symptoms are controlled, to increase the dose from 30 to 40, 40 to 60, or from 60 every 4 weeks to 60 every 4 weeks. But I do it more empirically. I measured plasma octreotide levels in approximately 30 patients, and I wasn't convinced that it provided me with information that I wouldn't have acted upon empirically.
Here's the comment, Gene, if I could. And Larry brings up the point in treating symptoms. Many of you probably experienced that at 3 weeks your symptoms start to come back, or you feel like you need the shot at 3 weeks versus 4 weeks. And I use that. I use the thing that says is more better, and rescue is very good, because you'll have folks saying, if I take 3 shots a day for a week more, I'm covered. And that's an indication then that you would bump the dose.
Okay. Larry, how does a local physician, Dr. Schmo in East Tennessee, become a phase 2 or a phase 3 site?
There are some patients from Tennessee in the audience I know, and don't be offended by his comment. I'm just kidding.
My wife's from Tennessee.
It is difficult for an oncologist in a small practice to become involved in phase 2 trials unless they join a consortium or become a member of a cooperative group such as the Eastern Cooperative Oncology Group or the North Central Cancer Treatment Group, the SMILE.
NSAP, big groups. Okay. So the little guy doesn't have a chance to do that. The reason the patient asks is most of these trials say if you're going to be part of my trial, you have to come back once a month, once every 3 months, at some kind of interval, and that makes it travel difficult and that expensive. You have a primary removed, and you're 4 years out, you're stable or you're progressive. Either scenario, do you need a new biopsy? Is a biopsy like tires? Do they wear out? Do you need new ones?
I have a very low threshold for repeating biopsies in people who've been free of disease for 4 years because the nature of the stripes on this zebra can change, and what was a grade 1 tumor with a Ki-67 of 1% may now be a grade 2 tumor with a Ki-67 of 12%. Rarely we see even more dedifferentiation where a tumor that was well differentiated can become poorly differentiated. So I have a low threshold for repeat biopsy with the appropriate staining in Ki-67.
Okay. And everybody up here, do you treat women and men different? Do you see different responses in women and men for octreotides, for chemotherapy, for pathology? Odo, Larry, Rodrigo?
I'm an equal opportunity employer, and I have not seen in the various studies that we've done over the last 30 years any difference in the responsiveness of the tumor to a whole host of drugs between men and women.
Statistically, if you look at women's octreotide level on 30 or 60 or 20, they're about 15% higher. It's statistically significant, but not practically different. Any thoughts on calling our disease, I don't know what disease ours is, the Steve Jobs disease, a la Lou Gehrig's disease? Don't think so. Moving right along. Any studies going on in the U.S. with virus therapy? New hot ticket, you know, pardon my French, I don't mean to honk off anybody. Yeah, I do. Big push to raise $2 million in Uppsala for oncolytic virus therapy. What do you know about that, and how effective is it? Would you send them a check for $100,000?
Even if I was Bill Gates, I wouldn't send them a check for $100,000 tomorrow. They've been working on this for several years already, and it's a fun concept, but I don't think that it's prime time for that approach.
Yeah, send your money to somebody in America. I think you're better off. Let's see. Metastatic insulinoma and Vomex, which is better, PRRT or Pemidronate? Why not use them both? Next. Valproic acid, black raspberry, pros and cons. Yeah, let's not do that. Dr. Rivera, U.S. shows, or ultrasound shows enlarged area of bile duct on pancreas. Patient can't do ERCP, prior pancreatitis. What's the best way to be sure that any kind of ductal dilatation or whatever is in there? Is that a case for the U.S.?
Absolutely, and patients who, I mean, very rarely would there be a contraindication to an ERCP, but certainly the images that you get with endoscopic ultrasound are pretty clear when it relates to the biliary tree and the pancreatic ductal system, so absolutely, it gives you a lot of information.
Okay. Based on our finding that tumor cells may be different than lymph nodes and liver site, should patients that were biopsied in the past be retested? I guess if you have progressive disease, you have to ask yourself, how easy is it to get extra tissue? A major exploratory laparotomy that costs you a week in the hospital to get a biopsy, probably not a good thing. If, on the other hand, a colonoscopy can get you access to a nodule in the ileum or whatever easily, then that's probably not a dumb idea. Thank you note for Dr. Odo. Okay, he has a big enough head, we're not going to take it. Let's see. I have consistent trough levels. I assume they're talking about octreotide. I am asymptomatic if my tissues are in fact saturated. Why do I need rescue shots? In other words, question is octreotide's effect, is it purely on the tumor, or is there an effect on other organs like lung? Larry, I always loved your story about the wheezing lady with the asthma attack. Odo, you talk about end organ response. You guys, you talk to, it ain't just the tumor that octreotide goes after. It's the end organ, and let them talk about that.
Well, what Dr. Waldring is referring to about my lady with a bronchial carcinoid is the fact that octreotide is a powerful inhibitor of substance P, and substance P is a powerful constrictor of bronchial smooth muscle. So this lady had profound asthma, and she ran out of her drug and came in to see me after she'd been on it for about 9 months, and we did pulmonary function tests, and they were severely impaired, and I got a call from the lab and then saw the patient. It turned out she'd run out of the drug and hadn't given herself a shot that morning. And this had nothing to do with elevated 5-HIAA, but with elevated substance P. So the compound works on the GI tract. It slows down intestinal motility. It blocks substance P, which has the ability to cause profound bronchoconstriction. So it acts on end organs other than just the tumor.
Just a comment to that. If you go back, and somatostatin was brought up yesterday, but if you go back to somatostatin's work, it was estimated that by 84, 85, when Larry and I were working, that there had been 5,000 papers on somatostatin. And one of the things that it clearly established was the dual mechanism of inhibition of peptides from a tumor, clearly like substance P, but also antagonism at the receptor for some of these hormones as well. So it has a dual action both on the target as well as the tumor, and that's what you have to remember. It's not just one.
Okay, Odo and Larry, another one before we get to Dr. Vienna. What's the best way to tell if your disease has spread to the lymph nodes without going and taking them out? What do you use, scans, or do you recommend surgical exploration just to evaluate nodes?
Well, the common diagnostic testing, including Optria scan and CT and MRI with EOBIS now, can evaluate lymph nodes, but on CT or MRI, the lymph nodes have to be above 2 centimeters to be considered pathologically enlarged. In other words, you and I have lymph nodes in our groin, along our aorta, under our armpits, and in the base of the mesentery that holds the intestine in place. But those lymph nodes can be 1.5 centimeters, and when we see them on a CT scan or an MRI, we can't tell if they are involved with cancer cells.
And I think that we're going to hear from the folks like Odo who are doing gallium-68 scans, that what used to be 2 centimeters, the next, what I call the half scan. Everybody knows about the half scan. The gallium-68 gives you half the cost, half of the time to do the scan, and half of the radiation. It's the half scan. That's you can say you heard it here. Okay, Dr. Vienna, would you tell us what point in treatment in a NET patient the patient should be at least evaluate or have a discussion about multivisceral organ transplant? What knocks you out of the game, and you know, when do you have enough so that they ought to be sent to you?
I think it's still an evolving question, but basically, I think if you have one of the tumors that is progressing, especially I think the pancreatic tumors have been a little more aggressive. You have metastatic disease in the liver. You haven't responded well to treatment. I think that's the time maybe you should look into it. I think in the future it might change. You might approach this earlier, or you may use a combination of treatments. Maybe you get the multivisceral, and then you will do prophylaxis, or I can give you a big biopsy actually with the multivisceral transfer. You can look at everything, all the tissues, and then you can customize a possible treatment for later. I mean, that might be an approach too for the future, but I think those are the patients that we should look into it.
Certainly, if your doctor tells you it's time to go home and die, you have to ask yourself, you know, do I have something to die of? In other words, just because you have a liver full of disease doesn't mean you have to go home and die. Just because you have a pancreatic tumor and a liver full of disease doesn't mean you have to go home and die. Now, there are some things that knock you out of having a multivisceral organ transplant. If you have a brain met, you're not eligible. If you have bone mets, you're not eligible. If you have disease that's growing out your abdominal wall through you're an old wound or something, you're probably not a good candidate. But just because you have a liver full of disease, or a pancreas and liver full of disease, or small bowel involvement in the mesentery that's twisting your guts up into a knot, don't go home and die. Talk to us. Let's get you evaluated for an MVOT. Larry, Timidar and Xeloda, does it hurt my kidneys?
No, in contrast to some of the earlier agents that we used for carcinoid and neuroendocrine tumors of the pancreas, like streptozotocin, the Xeloda and Temodar do not have renal or kidney toxicity. The major toxicity with Xeloda and Temodar is the possibility of mouth sores, stomatitis, possibility of diarrhea, possibility of hand-foot syndrome, and the possibility of lowering of blood counts, but it does not have cardiac or kidney toxicity like streptozotocin and adriamycin.
Which is important, especially if you're thinking downstream of PRRT. You don't want to burn your beans, okay? If octreotide is so effective, why is it still off-label? I don't know who wrote this. Octreotide is approved in by the FDA in the United States for the treatment of carcinoid and islet cells that are symptomatic. It's FDA approved. I don't know which use is off-label for you, so maybe ask that next time around.
In actual fact, the indication is just as Gene said. When it first came out, it was for the carcinoid syndrome and the watery diarrhea of VIP secreting tumors, and only recently was it approved for acromegaly, the growth hormone secreting tumor. But there have been 81 different uses for it up through 5 years ago. There's been publications for its use in in any one other entity. So that's maybe what the referral is to, for out of indication.
Okay, there are going to be three of us I'm going to ask this question, because I think it'll be interesting to hear how a surgeon, an endocrinologist, and a medical oncologist approach this. How to choose between PRRT, SurSpheres, percutaneous infusion, and systemic chemotherapy for a patient. I'll start. The first thing I do is I believe in my heart of hearts that you use a regional therapy for a regional problem. Use systemic therapy for systemic problems. If your problem is in the liver, you have a regional problem and you need a regional therapy. You don't burn the bridge for a systemic therapy if you can still use a regional therapy. So don't use chemotherapy, don't use PRRT. If you have a liver-only disease, SurSpheres, infusion. Likewise, the opposite case. If you have widespread systemic disease, bone disease, node disease, liver disease, supraclavicular nodes, mediastinal nodes, etc., you don't need somebody sticking a needle in and burning a liver met. That's meddlesome. You need systemic therapy. Larry?
I think that we're not far apart philosophically on this approach. The exception nowadays for me is the pancreatic neuroendocrine tumors, because as I showed you in one example, and I've got 50 others I could show you, the objective tumor regression with Xeloda and Temodar and pancreatic neuroendocrine tumors is seriously for real. It's very impressive. It's the most impressive chemotherapy I've seen in the 40 years I've been doing it. The liver-targeted therapy, whether it's radioembolization, bland embolization, or regional perfusion, is profoundly effective for liver-only disease. But if you're going to do that, it's critical that you have an octria scan to make sure that you don't have a lymph node hidden above the collarbone or a bony metastasis somewhere, because then systemic therapy is going to be much better. And if in fact the postulate in this question was peptide receptor radiotherapy was available, if there is disease in carcinoid patients beyond the confines of the liver, peptide receptor radiotherapy would be my go-to drug.
Absolutely. Systemic therapy for a systemic problem.
And I just to enforce the idea of options become combination options, like step 1, step 2, and particularly with temozolomide and Xeloda, we have actually seen tumors as much as 60 and 70% shrink down to almost zero and allow a window of time for the primary to be resected safely. And I think it's dramatic to preface that kind of a setting with the option of temozolomide and Xeloda with the intent that if we have enough shrinkage and it's safe, you go back to the original, to the main therapy that we've heard about, namely surgery.
Okay, this is a life threat on Dr. Odorizio. I just heard about crediting scores in gallium-68 SUVs. Are you going to tell us about that this afternoon, or do I have to kill you?
The standard, and as was alluded to with the Lutathera therapy that Larry spoke to, is still going to be the Krenning gold standard. But what now the Gene is asking...
Now listen to what you said. This is really critical. So if you do an octria scan and a lesion is there on your MRI and it doesn't light up on the octria scan, the fact that it lights up on a gallium-68 scan doesn't mean that you're going to respond to PRRT.
At this up to this moment, they're now establishing SUVs from a PET scan, a gallium scan, a minimum SUV and analogizing. We have a study that is going to go toe to toe, and I'll talk to that this afternoon.
Okay, so we are going to have to kill you. Okay, good. You're going to talk about that. Good, Dr. Coles. what's new, what's hot, if I have a high-grade neuroendocrine cancer, you know, what's the right thing to do there? Is PRRT work in high grades?
Unfortunately, when the tumor is more dedifferentiated and has a Ki-67 above 20%, the tumor has usually down-regulated production of somatostatin receptors. So it's very, very rare for us to see a positive Octria scan in poorly differentiated or grade 3 tumors. Those are the Ki-67 above 20%. Very, very rare.
Okay.
So the standard treatment that we first published when I was at the Mayo Clinic, that is now accepted around the world as standard for poorly differentiated neuroendocrine tumors, the gold standard is now way too old, and I wish we had something even better. But that's a combination of etoposide and cisplatin, also called Bepacid and cisplatin. This combination we initially reported as having an objective response rate of 67%, and that figure has been corroborated by numerous publications from Australia, Europe, South America, and the U.S. It's still a standard.
Tell them the opposite side. What's the trouble? You get 70% of people who respond. How long do they respond?
Yeah, and
That's the trouble.
the other thing is 30% of patients don't respond. So,
And even the people who do respond, what's the median duration of response?
usually only 12 to 18 months. So it's a huge problem. And for the first time in more than 15 years, we've got some moderately active second-line therapy. The same combination of Xeloda and Temodar, which is so active in pancreatic neuroendocrine tumors, was shown by one of my colleagues, Wayland, in Uppsala, Sweden, to be effective as second-line therapy in poorly differentiated neuroendocrine tumors in about 25% of cases. So that's the first combination we go to if people fail to respond to etoposide platinum, 30% of people, or if they respond and then recur. Other drugs that can be used in this setting are Taxol, Taxotere, and to a lesser extent Cytoxan, Adriamycin, and Kristen.
And that was the one thing I wondered, Larry, when you did the original, the seminal work with Temodar and Xeloda with the high grades, you chose not to look at them at all. Is that right? You didn't study?
We did, and I was pleasantly surprised when Stefan Wayland in Uppsala decided, hey, if it works in the grade 1, grade 2, why not try it in the grade 3, and he did, and so we've adopted that.
Okay, this is a question that addressed to Larry, Odo, and I. It's basically the yttrium-labeled somatostatin analog and the lutetium-labeled somatostatin analog bind to what receptors? SST2 predominantly, a little less SST5. Both the lutate and the DOTATOC are a little more avid in their binding than the old-fashioned octreotide, but again, receptor 2 is top. Quality of life. Wants a show of hands. Who's affected by fatigue and tiredness as much as pain or diarrhea? So if you have fatigue that is as big a problem as pain or diarrhea, raise your hand. Okay, so there the fatigue. Have your doctors looked at B12, thyroid functions, etc.? The answer is almost inevitably yes. And I have a group of people who have fatigue, that they have normal thyroid functions, normal B12, they're not anemic, and they just have fatigue. And some of those people are on octreotide, some of the people are not on octreotide, some are on high dose, low dose. Fatigue is just ubiquitous.
It really is, and Gene brought up a point yesterday, and he used a specific thyroid test. You get eventually secondary hypothyroidism. Larry spoke to that initially before anybody else, but that's one of the actions of Sandostatin, is to inhibit the hormone that controls the thyroid. But when you get thyroid testing, you only get a TSH. You sometimes get a free T4. But as Gene noted yesterday, it's the free T3 that's the Action Jackson. And there appears to be a conversion problem between T4 and T3 with Sandostatin, so that you ask them to draw a free T3 for you. It's invariably low, very low, and that's one of the main,
And the drug you use to fix it is a little bit different than Synthroid, which goes to T4. It's triiodothyronine, and which goes to T3.
And so if you give Synthroid T4 all the time, you're still going to have that problem between the conversion. So some of our folks they get the preparation T3. There's 2 thyroid hormones.
See, even a surgeon can learn endocrinology.
It's good.
It ain't real hard.
To try the short acting as well as the regular T3.
Okay, my uncle has carcinoid, my grandmother has carcinoid, I have carcinoid. I'm the only living one. Would Dr. Wank like me in his hereditary trial at the NIH? Boy, he'd love me. Moving right along. Should all patients with carcinoid tumors that have metastasis to the liver be given Sandostatin injection? So if you have a metastasis, a metastatic to the liver, do you put everybody on Sandostatin? And should anybody die without the benefit of Sandostatin? Even if you don't have flushing or diarrhea?
Yeah. The PROMET trial that I talked about involving 85 patients in Germany, the majority of them did not have a carcinoid syndrome. They had biopsy-proven liver mets in the liver. The patients who got Sandostatin versus the patients who got placebo went more than 2 times longer before disease progression. So in my opinion, the presence of liver mets is an indication to start Sandostatin, because if you'll remember, I pointed out that the patients who had a very low tumor burden, less than 10% of the liver replaced, if they got Sandostatin, went about 28 months before progressive disease, as opposed to those that got placebo who went 7 months.
You're going to love this one. I'm not making this up. I couldn't make this up. Dear Sandostatin Swami, you have a new nickname, Sandostatin Swami. Around the U.S., various Medicare offices are denying payments for Sandostatin over 30 milligrams every 3 weeks. What arguments do you make for that, the federal government or their insurance company to cover higher doses? That's a good question.
You're
I
right.
like the Sandostatin Swami.
It's a very good question, because it's a very real problem. The approach from insurance companies varies from region to region of the country. In my instance, I'm very fortunate to be at a comprehensive cancer center, and fewer questions are asked when you do something at a comprehensive cancer center than when you're in a small city in Wyoming. But it's an issue, and sometimes we do have to write letters for people who are trying to get it in Cheyenne, Wyoming, and we'll present an abstract that we presented at ASCO to back up the fact that majority of patients who go from 30 to 40 in the face of poorly controlled symptoms, or from 40 to 60 in the face of poorly controlled symptoms, achieve symptomatic improvement, and it also can achieve cessation of progressive tumor growth when they progress on a lower dose and then go to a higher dose. But it's not approved in the package, so it's going to continue to be a bugaboo.
So he picks on Wyoming, I pick on Tennessee. Okay. I think this is a place where blood levels can also help you. You know, instead of subjective, my symptoms feel better, a blood level is an objective measurement. So if you have symptom progressing and you have low blood levels, it just adds another piece of data that they can't argue with. They can argue with the fact that you have 6 bowel movements a day versus 4 bowel movements a day, but it's hard to argue with a blood test. Dr. Vienna, can multivisceral transplants be successful with mets to the peritoneum, i.e., can you do a peritoneal resection take the whole envelope back? That's a good question.
We've been discussing about that. I think right now we have not done that yet. I think what happens is that you probably, once you have disseminated what's called, carcinomatosis, I think it's more likely that you have disseminated disease, so we have not tried that. Now, technically, is it possible? Yes, it's possible. But I think we have to go into steps with this so we don't ruin the idea. So I think that's an approach, but I don't think we should be doing those right now because I think it's difficult to remove all the disease without contaminating the entire thing. So right now, we're not doing that.
I would just ask also Dr. Viana regarding the so-called cocoon phenomenon where folks are obstructing because of the desmoplastic formation of the bowel. Do you encounter that because that's a hard diagnosis to make even before surgery? Do you encounter that sort
It's
of...
pretty easy to see on scans.
When it's late.
Yeah, when it's late, and we
Yeah.
actually have sent some folks to Rodrigo with cocoons. So this is a good question. There's a zebra lady here who needs to listen to this answer.
Yeah, no, we've seen, with because multivisceral transplant, not only for these tumors, we see people that have, very extreme conditions and diseases. So yes, we do see frozen abdomens and, it's very difficult. I show you one of the pictures and you couldn't see anything. It was just the tip of the liver. So yeah, we've seen cocoon syndromes and frozen abdomens with the disease.
And again, just because you have a cocoon or you're having recurrent small bowel obstruction, this is one of the cases where Rodrigo, instead of going to the tomb, go to Rodrigo. Dr. Rivera.
Just for 1 second, the one thing that we've been talking about is auto-transplantation. Sometimes you can't do the resection in vivo, but actually if you take the organs out, like you're procuring from a donor, potentially you can resect a lot of tumor and put the organs back. It's something that you can't do because people will bleed out.
Remember at the last conference, Dr. Seju Joseph talked about taking your liver out, putting it on the back table, cooling it down, icing it down, and now you have hours to work on a liver that has no blood. You can't bleed for a liver that has no blood supply. Now you put and then you take the liver that you've taken 150 tumors out of under ultrasound guidance. Now you put the liver back in. And that's been done, I believe, in Scotland? Yeah, Scotland predominantly. Okay, Dr. Rivera, how small lesion can you visualize with EUS?
So as I mentioned before, the visualization of the lesion is very, very easy. You can see lesions that are small, 1 to 2 centimeters, especially in the pancreas. When we're talking about the small bowel, the region that you have to survey to find a lesion that's 1 to 2 centimeters makes it much more difficult. So when you're looking for a lesion in the stomach or small intestine, it's always best that some sort of lesion is identified with four-view endoscope, the regular standard endoscope. For pancreas, it's completely different. It's much easier to find those little lesions in target.
Let me just ask technically, Dr. Rivera, when you go down with your endoscopic ultrasound, it looked like one picture had the scope in the center of the bowel and you almost had a 360-degree ultrasound. Was that true, or was I wrong?
That's correct. There are two modalities. One is that radioscope that gives you a 360 image. The problem with that is that there's no fine needle aspiration with that, so you can't do biopsies with that. So you will have to identify the lesion and switch over to what we call a linear scope, which is a more limited view, but you're going to target the lesion that you identify with the 360 to be able to biopsy these lesions.
Can I ask a dumb question? Why can't you use two scopes at the same time?
That's a good question. They've designed it should be out shortly. They're trying to come up with scopes that combine both modalities. That's a matter of software.
Rodrigo, talk about insurance coverage for MDOT. Can you talk about the process? How do you know, what's the testing involved? Do you have to move to Indiana for a period of time? And what's the recovery time from the time you get your transplant till the time you can go back home?
All right, so quickly, with insurance companies, again, it's not a approved Medicare indication because we haven't done enough. And there's few centers doing, so most of the times we require discussions between the insurance companies and us. Most of the times we can get it, although there are a few patients that we couldn't do it. The timing, usually the waiting time is about 3 months. Recovery time, people stay in the hospital about 3 weeks. Not because they're sick, it's because we have to switch them. They get an intestine, your stomach, everything. So we have to switch them to oral diet or enteral feeds, get them off TPN. Usually people stay around for about 3 months. So if you want to do this, you have to take pretty much 3 months waiting time plus 3 months after. So it's going to
So
be
6 months you're in Indiana.
Yeah.
Okay. Unless you're an Ohio State Buckeye, that would be intolerable, but otherwise. Temozolomide and capecitabine, or Xeloda. Larry, I think you answered this already. It doesn't cause problems with your kidney, so it doesn't screw up PRRT. Am I right? Okay, cool. Can there be one more, or more than one type of cancer cell in a tumor? Yeah, I think that, this is really fascinating. Everybody thought tumors were what are called clonal. And that, if you had a jelly beans in a jug, they were all black. And yet, like people have done scans of the liver, and they have 2 lesions in the liver. Dr. Bergolini, I remember, does this. And she shows that of the 2 lesions in the liver, one lights up on an Altria scan, and the other one lights up on a lanreotide scan, both of which are somatostatin analogs that go after type 2 and type 5 receptors. So the answer is, I think more and more we're recognizing that tumors aren't homogeneous, that they're heterogeneous.
And to that point, yes, and to that point, it's not a bad idea when you're doing the Altria scan also to do the PET scan, the FDG PET scan, because after therapy with PRRT, we found patients coming back with resistant lesions that which were very positive by FDG PET. Not always a good scan for neuroendocrine tumors, but in this instance it is, and it is very predictive to Larry's point, and they showed in France that an SUV above 7 or 8 with a PET scan, FDG PET, responds better to the advanced chemotherapy that Larry mentioned. And it's a very good idea in some of those lesions that seem resistant or progressed to do an FDG PET.
Okay. Everybody, what chemotherapies are also anti-angiogenic? Taxol clearly is, vincristine is, apothulone is, RAD001 is anti-angiogenic, Sutent is, somatostatin analogs are anti-angiogenic, PRRT destroy vessels. Did I miss any big ones? Okay. Dr. Coles, Luthera trial, will it include non-carcinoids? And if not, if it's shown to be effective and FDA approved, are the peanuts folks screwed?
Outstanding question. The trial is limited to carcinoid patients. The company who's sponsoring the trial is AAA Advanced Accelerator Applications, an Italian-based company, and they are looking for an opportunity to get the drug approved as rapidly as possible in the USA and Europe, and by having a single indication, they think they can get it approved more rapidly. But that will leave those of you with pancreatic neuroendocrine tumors up the creek if it is approved.
Out of indication.
It'll be another out of indication, and we'll write letters and do our damnedest to get approval to treat you with it if it gets approved, but it's one of the limitations of
Okay,
the
guys,
trial.
I'm down to 1 minute and 22 seconds. I developed interstitial lung disease with Afinitor. Is it safe to assume I could not use Afinitor and Timgar? I think so. Yes?
The interstitial lung disease seen with Afinitor if you recognize it early enough, the infiltrates primarily in the lower part of the lung fields is reversible. With discontinuation of the Afinitor, sometimes if it doesn't resolve on its own, the addition of prednisone will hasten resolution. And that's why we routinely do chest x-rays at 3-month intervals, so that if we see it, we can stop it. And if it resolves, then we restart the drug at 5 milligrams instead of 10 milligrams.
Okay, I'm going to ask 2 more questions and then we're done. Dr. Rivera, any relationship between NETs and hemorrhoids? If I have a large hemorrhoid that's asymptomatic, should I have them checked? Or are they just hemorrhoids and not have to worry about it if they're not bleeding and not hurting me?
Yes, if there's, I mean, certainly if there's rectal bleed, the first thing you want to know is that there's nothing aside from hemorrhoids going on higher up in the rectum or the colon. So that's the first step. And then based on the dividing the hemorrhoids of internal hemorrhoids or external hemorrhoids. But to answer the initial question is that no, there's no specific relation of neuroendocrine tumor unless there is some sort of vascular compromise that I can think of.
Cool. And I don't know of any relationship between hemorrhoids and rectal carcinoids, etc. Last question, Dave. Rodrigo, other than bone nets and bone marrow disease, what are the other things that knock me out of the box for MVOT?
All right, so except for extra abdominal disease, of course, if you have a very bad heart, like you have to have a good heart to survive the operation, lung function, pretty much those are, we pay a lot of attention to the heart and to the lungs. And if you have any other malignancies or anything that would preclude the transplant. But basically, if you're limited to intraperitoneal disease with no other contraindications.
People who can't take care of themselves, can't live independently, people who are crazier than a bed bug. Right? Thank you all. It's lunchtime.